Okay, I can see your slides.
Great. And then if I just stop sharing, does that allow you, or I have to hit stop showing screen? Okay.
So, okay. And then, can you see my slides now?
I can see them. They're kind of like in a small box.
Better.
Okay. Yeah, that's better. Yep.
Okay, perfect. And I'm gonna take them off real quick, and this is working well. And then, okay, I see Catherine is on there. Awesome. So we'll keep you presenter afterward, and then she'll just be on camera, right?
Yep. Yeah, I will be the main presenter.
Thank you so much for joining us and for agreeing to do this. We're excited for this stuff.
I'm excited. Can you guys hear me okay?
Yes,
Yep.
very well.
Perfect.
Can you hear me okay?
Mhm.
Okay, wonderful. So sorry. I'm gonna try and turn my camera on. I just have to figure out how to do that. Oh, there we are. Hello.
Awesome. Thank you. We can see you and we can hear you.
All right, perfect. And I will mute my mic as needed because I am at my job, so there's noise going around behind me.
No problem. I'll do the same. We'll start with the introductions and the slides, run at 3, and then I'll hand it over to you guys.
Okay.
Awesome.
You're muted, Rita, if you're.
Thank you very much. Good afternoon, everyone. Welcome to the quarterly Southeast chapter of SCCM meeting. We are excited that you're taking the time to join us today. We have a wonderful panel of speakers who are going to be talking to us about early mobility in the ICU. And before we jump into their introduction, we'd like to go over our chapter mission and vision. So our mission is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. And our vision is that all critically ill and injured persons in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. Our chapter covers 7 states in the Southeast region. We are a multi-professional organization, and our goal is to really encourage both SCCM and chapter membership while providing education networking opportunities. Today, we have the pleasure of hosting Dr. Heiser, Catherine Orbronowski, and Deirdre Clark, who are of the wonderful rehab team at Johns Hopkins, who will be talking to us about early mobility in the ICU. Before we go into that, I want to make sure everyone is aware of our CE instructions to obtain CE. So CE is available for all the members of the chapter. It will be available for the CE survey will be open for 2 weeks from now. So it closes on Thursday, August 31st. If you'd like to scan the QR code, there will be questions that our speakers will go over throughout. So please make sure to take note and fill in your CE as you're going through the presentation. During the month of June, we had a wonderful bite-sized lecture from a toxicology and ED group out of UAB in Birmingham, who spoke to us about a toxicology case where ECMO was actually employed for patient resuscitation. This lecture is now recorded and available on our YouTube channel, in case you missed it. In August, we also hosted our annual ultrasound course, which was hosted in Atlanta right before the Critical Care Summit, and we had 14 participants, and it was a very helpful course. We always look forward to hosting courses. If you're interested in your region to bring an SCCM course such as FCCM or any other courses, please reach out and we can look for opportunities on how to collaborate and make that happen for your institution. In September, we have our Spike Out Sepsis event coming up. This is an annual event that our chapter has been hosting, which is meant to be an amateur volleyball tournament, which is a lot of fun for both amateurs and expert volleyball players alike. We use this time to celebrate Sepsis Awareness Month, which is September, and to raise money for Sepsis Alliance, the organization that leads sepsis research and awareness. We ask you to join us. We'd love to have teams from all over This is a great way to network, communicate, have a great time. And it's also a team building activity if you have a team from your institution or from your unit. If you're unable to come in person, we have opportunities to actually support different teams as well as support the organization online. So if you visit Spike Out Sepsis online, you'll be able to see our event and you can donate directly to the teams that you're supporting. Any questions, please reach out to us on communications@sccmse.org, or you may directly reach out to any of the leadership and we're happy to provide you with the information. The deadline for team registration is the beginning of September 1st. So again, feel free to reach out with any questions. The event is actually held in Chattanooga this year, Chattanooga, Tennessee, and it's a one-day event. It will be on September 16th, which is a Saturday. We usually start around 10 and we conclude by 2 or 3 p.m. So if you are close by, you can certainly, make it a one-day trip. Again, we look forward to triaging any of your questions and look forward to your support. October, we have a couple of events planned. So we're working with Gaspin, the Georgia chapter of Aspen to host a joint nutritional program on critical care nutrition. We also have a group that will be speaking to us, a multi-professional group that will be speaking to us through a bite-sized lecture on pulmonary embolism management. So please look forward to more information via our email listserv as well as our social media platforms. We always look forward to you supporting us through Amazon Smile. Here are our membership benefits. And again, feel free to visit our website or reach out to any of the leadership for questions. And with that, I'm going to stop sharing my slides and I'm going to jump directly into our wonderful speaker introduction. So our speakers today are out of the Johns Hopkins group, ICU rehab group. We have Dr. Stephanie Heiser, who's an assistant professor in the Department of Health, Human Function, and Rehab Sciences at George Washington University. She earned a doctorate of physical therapy from University of Miami School of Medicine and continued her clinical training by completing an acute care residency for physical therapists at Johns Hopkins Hospital, partnered with the University of Delaware, and then a critical care fellowship for physical therapists at Johns Hopkins Hospital. Additionally, she became board certified physical therapist in cardiovascular and pulmonary physical therapy. She completed a PhD in clinical investigation at Johns Hopkins Bloomberg School of Public Health in May of 2023. She has practiced across the breadth of critical care patient populations at Johns Hopkins Hospital and collaborated on a variety of research projects in the ICU setting. She has published much of her work in peer-reviewed journals. Additionally, we also have Ms. Catherine Urbanowski, who is a lead clinical nurse in the medical ICU at Johns Hopkins Hospital. She earned her Bachelor's of Science in Nursing from St. Anselm College, and the entirety of her nursing career thus far has been focused on caring for critically ill patients. She worked for 3 years in the Neurotrauma and Burn ICU at the University of Massachusetts Medical Center and then transitioned to the MICU at Johns Hopkins Hospital. She obtained board certification in critical care nursing from the American Association of Critical Care Nurses in 2019, and during her time at Johns Hopkins, she had advanced up the nursing clinical ladder and currently maintains a management position. She sits on many practice councils throughout the health system and collaborates on many improvement projects. And last but not least, we have Ms. Deidre Clark, who is currently a respiratory care practitioner at Mercy Medical Center. She earned her associate degree in respiratory care and a bachelor's degree in health sciences from Gannett University. She was a respiratory therapist at Johns Hopkins Hospital for 10 years before transitioning to Mercy Medical Center. She continues to present at the annual Johns Hopkins Critical Care Rehab Conference regarding the role of respiratory therapy in the ICU and other interprofessional presentations with the Johns Hopkins team. We are very, very excited that this awesome panel is joining us today. And with that, I would like to hand it over to our speakers. So I will change the presentation mode so that y'all can share your screen.
It's not giving me permission yet. Oh, there it goes.
Awesome. Thank you. We look forward to your talk.
All right, so we'll go ahead and get started because I want to definitely leave room for any questions that you all may have at the end of the presentation. We are very excited to talk about something I think the three of us are very passionate about, and that's early mobility in the ICU, and really talk about this interprofessional collaboration, which is key for successful early mobility programs. So these are some of the objectives. We really want to talk about key outcomes of early mobility in the ICU, talk about important steps for successful implementation and sustainability. We'll talk about some of the common barriers to early mobility and strategies to overcome those barriers. And then we'll talk about the specific roles of physical therapists, nursing, and respiratory therapists. So we'll start off with talking about early mobility outcomes. So there's been more than 150 studies looking at early mobility in mechanically ventilated patients in the ICU. More than 50 of these have been randomized controlled trials. There has been shown a signal for potential benefit to muscle and function, as well as delirium and cognition, and is conditionally recommended by the Society of Critical Care Medicine in the PATIS guidelines published by Devlin et al. This conditional recommendation is really based on the fact that the quality of the evidence is a bit low, which we'll discuss a bit further in the next few slides. But based on the evidence, it was concluded that the desirable consequences outweigh the undesirable consequences of early mobility. However, we must note the inconsistent findings in the literature regarding efficacy of early mobility, but this topic alone could be an hour or more presentation, so we will not do a deep dive on that topic. But some of you may be familiar with the recently published TEAMS trial in the New England Journal of Medicine at the end of 2022, and I'm happy to entertain any potential questions at the end regarding that study. So we'll jump into our first systematic review and meta-analysis that was published in Critical Care Medicine in 2021 by Wang et al. So they included 60 studies in their review with 5,352 patients. One thing that I really like about their systematic review and meta-analysis is that they stratified their control therapy or the control therapies in these studies into high versus low dose intervention, meaning high dose was greater than 5 days a week of rehab and low dose was less than 5 days a week. And the reason why I like this is that the literature has significantly evolved over the last 20 years. So when early rehab literature first started to emerge in the early 2000s, really the studies were comparing an intervention to essentially no rehab in the control group. But over time, as there has been the translation of research into practice and more institutions have implemented early mobility programs, we're really now comparing intervention to some other form of intervention. So that's a key thing that I think they really took into account in this review that I really liked. And so what they found was that 31 of the 57 randomized controlled trials that they included in this review showed a high risk of bias. This was either due to deviations from the intended intervention or poor reporting of the interventions. And so what we mean by this is that deviations from the intended intervention, many of these early rehab interventions are challenging to make sure that the patients that are enrolled in the study receive the intervention that was intended, every single day that they're enrolled in the study. That could be either due to some sort of medical procedure that occurs on, 1 or 2 days and they're, not able to participate in the intervention, or the patient may defer a session or want to stop the session early. And so that is a deviation in the intended protocol. And sometimes those sort of nuances aren't always discussed in the limitations of the study or taken into account with the analyses of the studies. Additionally, sometimes the details regarding the characteristics of the intervention, so the duration of the intervention or how often the intervention is delivered, or even the type of intervention is not thoroughly reported. And so if a study says that they're delivering early mobilization 5 days a week and they don't give any other characteristics, it's a little challenging to know what they were actually delivering, because if we say early mobilization, that's a bit of a Pandora's box as far as what interventions that can include. But this review found that there was a reduction in mechanical ventilation duration of about 1.5 days in the intervention group compared to the low dose control therapy, a reduction in the ICU length of stay of about 2 days in the intervention group compared to the low dose, and then a reduction in hospital length of stay of about 2.5 days in the intervention group compared to the low dose group. Physical rehab resulted in a small improvement of physical function at hospital discharge. And as you can see, that effect size here is on a bit small. And then when we look at the muscle strength, there was no significant differences at any time point between the control versus the intervention. And they found that the greatest benefit was with functional exercise as being the intervention provided. And then if the intervention was compared to a low dose control group. Some of the limitations include heterogeneity in the outcome measures that were evaluated in studies, and then also the reporting of the interventions. All right, so we'll start off with one of our first questions here. And so you guys can join the poll by either scanning the QRS code in the top right corner here, or you can send a text Stephanie Heiser 214 to 37607 to answer this question. And so the first question being, according to Wang et al., select one major source of bias mentioned by the authors and this presentation found in the studies included in the systematic review and meta-analysis. And I'll give you all a little bit of time here to sort of get plugged into that poll. Again, you can send the text Stephanie Heiser 214 to 37607, or you can scan the QRS code in this top right corner here. And then for those of you that use the QRS code, you can sort of keep that open. As we go through the questions, it will change on your phone to the next question automatically, so you don't have to do anything extra or take any extra steps with that. I'll give a couple more seconds for those of you to respond and think about this question. All right, so for this question, it was really poor adherence to the intended intervention. So again, going back to, the studies weren't thoroughly reporting whether or not the patients received that intended intervention that was part of the study. All right, next question. So the previous Wang et al. Systematic review stratifies the control group into high dose control versus low dose control to take into account the following. Again, I'll give you guys a few seconds here to respond to this question as well. All right, and everybody was kind of right here. It was really A and B. It really took into account the standard of care delivered in recent trials because of the change in usual care, and then also the evolution of standard practice since the earliest trials. So these were both basically the same answer. All right, moving on to the next systematic review that we'll discuss that was published in Critical Care Medicine in 2020. This review included 43 randomized controlled trials, 20 being a physical therapy protocol, 14 being neuromuscular electrical stimulation, and 9 being in-bed cycling. They had 3,548 patients overall for these studies, and the median age was 60. The median Apache score was 20. Mechanical ventilation duration 10 days, ICU length of stay 15 days. They found that there were no serious adverse events. There was also no effect on mortality, and their outcomes, their in-hospital outcomes, are very similar to that prior systematic review that we just discussed by Wang et al. And the fact that there was a reduction in mechanical ventilation duration, ICU length of stay, and hospital length of stay. And this was even without sort of that stratification of the control therapy. And so again, we still see the signal there with the intervention. When they did a subgroup analysis, they found the benefit was greater with randomized controlled trials that were protocolized physical therapy interventions with a ICU length of stay reduction of about 2 days in the intervention group. And then the treatment effect was greater in patients with a longer length of stay and a lower severity of illness based on the Apache score. Another systematic review that was published recently in 2022 looked at early mobilization for the prevention and treatment of delirium. Among the 13 studies included in this review, early mobilization reduced the risk of delirium by 47%. And was also shown to reduce the duration of delirium by 1.8 days, though there was less studies in this analysis. Some of the limitations was that only a subset of all existing studies had suitable data due to heterogeneity to do this analysis. And then also, again, we have risk of bias was a major issue with these studies. In conclusion, early mobilization may help prevent and treat delirium, but we need consistent use of validated tools in future studies. So we'll now move on to talk about implementation and the sustainability of early mobility programs. And so the TRIP model, which is the Translating Evidence into Practice model published by Pronovost et al. This is a model used for large-scale knowledge translations. And so we'll go through each of these stages in the next slides, but I really want to emphasize the really the importance of having all key stakeholders involved in order to successfully implement early mobility programs. For example, physical therapists can't maximize a patient's mobility if the patient is consistently a RASS of -3 or a -4 every day when we try to see them. Thus, we really need to have collaboration with nursing, with physicians, with the pharmacist in order to make sure that we are, getting this patient to the point where they can really participate in the physical therapy intervention. So stage 1 of the TRIP model is summarizing the evidence. So we know early mobilization in the ICU is supported by the literature. So you can take this back to the key stakeholders at your institution. You can take those, systematic reviews and show that there's a reduction in mechanical ventilation duration, ICU length of stay, and hospital length of stay, and get buy-in from that context. There are inconsistent findings regarding certain interventions, such as the in-bed cycling, neuromuscular electrical stimulation, as well as tilt bed implementation. And so that may not be where you spend your time or your financial resources in regards to investing in equipment for your early mobility program. Stage 2 is identifying local barriers to implementation, within the context of your institution. So you really want to observe the staff performing the intervention, so early mobilization, and figure out what are the defects or the barriers along the way, and then enlisting all of the potential stakeholders that are involved in order to determine how you're going to mitigate those barriers in order to have a successful early mobility program. These barriers could be patient-related, structural, procedural, as well as cultural barriers. And we'll talk more about barriers a little later on in this presentation. A really important thing is measuring performance. I can't stress this enough. And, it's not only important to sort of measure what your baseline performance is, but you want to make sure that you continue to measure over the course of your implementation process, as well as onward, in order to make sure that you have a sustainable program and that you have, objective data to show whether or not your program has been successful. And so the measures that are used at Hopkins may not be, appropriate at your institution. You really do need to figure out what are the most, feasible measures to use with your clinicians at your institution. And then stage 4 is ensuring that all of your patients receive the intervention. And so using the 4 E's here, so engaging, you want to make sure that you explain why the intervention is important, and educate, the people that are involved in regards to the evidence supporting the intervention that you're trying to implement. And then develop some sort of toolkit or standardized process in order to make sure that the intervention gets executed and that there are checks and reminders in place to make sure that everybody is, doing whatever their role is in the intervention process as well. And then going back to measuring your performance, that's part of that evaluation process. So again, you want to make sure that you're continuing to measure, how often your patients are being seen by physical therapy, what is the highest level of activity that your patients are achieving, or what's the median, highest level of activity on your unit. So making sure that you're constantly measuring so that you can identify any dips in that trajectory. And then go back to identifying the barriers again. And it's sort of this constant cycle of processing and evaluating that as well. All right, so next question here, based on that Pronovost et al. Stages for implementing and sustaining a new intervention, such as early mobility. So once the evidence has been summarized, what was the next stage that we talked about that is important to do after the summary of the evidence? All right, you guys were correct. Identifying barriers is the stage 2 of that TRIP model. So making sure that you're identifying barriers at your institution. So this was a great article that was published in Critical Care in 2021 by Hodgins et al. Looking at 10 strategies to optimize early mobilization and rehab in the ICU. So you can see here, I highlighted the top 4, which are 4 that we're kind of talking about throughout today's presentation, in creating a multi-D team, which we have here today, identifying those champions of early mobility, using a structured QI process, so similar to the TRIP model, identifying barriers as well as facilitators is important. And then promoting multi-professional communication is key as well. And then for more resources, you guys can go to johnshopkinssolutions.com to find training materials for your team, as well as resources and tools that will help you implement an early mobility program at your institution. And now I'm going to turn it over to Catherine to talk about barriers to early mobility.
Awesome. So as Stephanie mentioned, identifying these barriers is part of helping you to progress through the mobility program. When we think about barriers, there, as Stephanie identified, there's multiple different types of barriers, and identifying them will allow you to switch that focus from, what is blocking us to how do we move forward through this. So as you can see from this slide, there's been a lot of research that has focused on identifying these barriers. Some of the barriers that I'm going to talk about are nursing focused, but I think as you'll see as we go along, and you'll be able to relate and understand that these barriers are not just for nursing, but for all disciplines as well. So this specific study looked at identifying barriers. So it was a review of 7 articles, and they identified 3 main themes and then 13 sub-themes among these 3 themes. So you can see the 3 main themes were broken down to organizational barriers, individual barriers, and then patient-related barriers. And you can see those 13 sub-themes throughout it. So within organizational barriers, staffing level was one of the most prominent themes. So among the studies, 47 to 71% of nurses expressed staffing levels to be the barrier to early mobility. So it was identified that the level of nursing experience and years of experience didn't impact this perception of staffing levels. Many nurses identified staffing levels as a barrier because of the need to have more than one person available during mobility, and the need to have staff with relevant skills to assist with that early mobility. In terms of individual barriers, 5 of the 7 studies identified nurses' fear of injury as a barrier to mobilization. There was feedback within these studies that said there's a limitation on training, and that contributed to the fear of injury being identified. A lot of the nurses reported that training was really focused for them on boosting up the patient in bed and not really getting someone either sitting at the edge of the bed or even transferring to a chair, and how to do that safely. Patient-related barriers focused on the perceived restrictions associated with mobilization. So multiple studies reported that nurses were able to identify that mechanical ventilation was not a contraindication. However, they would identify that intubation was a major barrier to early mobilization. So they know that it can be done, but they still see that as a major barrier. Other barriers included invasive lines and fear of dislodgement and patient refusal. Perfect. So this seems like a kind of, well, duh. Obviously, patient tubes and lines can be a barrier, but I think the relationship has not been explored to what extent they are a barrier. So the purpose of this study was to more fully understand the impact and just how much time is spent on organizing and maintaining these lines. So as evidenced before, fear of dislodging patient tubes and lines was identified as one of the major barriers to initiating. So really getting that patient, to the thought about mobilizing. But this study specifically examined, once the mobility session has been initiated, how much time is being spent on that. The paper examined observations from 22 early mobility sessions, and these were in 4 different ICUs. It was identified that about 61% or 12.2 minutes, which seems crazy, of therapy session time is spent on management of tubes and lines. So this included securing, organizing, untangling, creating slack or positioning of medical tubing, administration set devices, cables, or cords. They also identified that more than 25% of the ICU patients in this study required at least 12 patient tubes or lines. There was a correlation found between the number of lines and time spent managing and organizing lines, and then also the number of lines and the number of staff to assist with early mobility. So not only is the lines come in to be a barrier, but as you see, that's going to tie back to staffing issues as well, and that being one of the barriers as well. So this is actually one of the first studies to examine the impact of time spent having to manage tubes and lines during early mobility. Obviously, additional research really needs to focus on, how to decrease maybe the number of tubes and lines in these patients, but then also better management styles. So in summary, there's a lack of knowledge and awareness about protocols, and that can be one of the major barriers. There's also a lack of conceptual agreement with guidelines, lack of self-efficacy and confidence in implementing the protocol, and also just implementing early mobility. Staff and patient safety concerns, as we discussed, fear of injury to the staff, but then also fear of injury to the patient. There's cultural barriers, there's interprofessional team coordination, and we'll talk about that a little later on. Communication and collaboration barriers, lack of interprofessional team support and training, low prioritization and perceived importance of early mobility, and then also scheduling conflicts. So what we really wanted to drive home is the importance of identifying barriers at your institution specifically. So we give you the overarching barriers that have been identified, but each institution is going to have different barriers that are specific to them. And being able to implement these early mobility protocols and this early mobility is really going to come down to identifying those barriers and targeting those barriers that are specific to your institution. So we're going to go into a question. So what are the barriers to the implementation of early mobilization of patients in the ICU? And we'll give you a couple minutes to answer that. Awesome, so you guys did great. You all answered D, which was, all of the above, that all these play in and can impact being able to implement that early mobilization.
All right, so we'll now talk about the specific roles of each of our disciplines. I'll start us off with talking about sort of the role of physical therapists in the ICU. So as a physical therapist, our role is to determine the resulting impairments from a health condition that landed the patient in the ICU in the first place, and how those impairments limit their activities and their ability to participate in whatever their social role is, whatever their house role is, that sort of thing. We also consider how their environmental and personal factors influence those impairments and limitations and restrictions as well. So as physical therapists in the ICU, one of our major roles is identifying barriers to maximizing a patient's mobility. So starting with identifying any barriers to safe patient handling and making recommendations regarding safe patient handling. So do we need specialty equipment? Is additional assistance needed? Understanding how any medical or surgical procedure may impact a patient's mobility. Identifying any barriers from any drugs the patient may be on, whether it's sedation or vasopressors. And then understanding any implications of abnormal lab values and how that could impact a patient's mobility, whether it's a low hemoglobin, whether it's a increase in the patient's potassium. So having that understanding and knowing how that may influence a patient's ability to progress with mobility is important as well. And then identifying barriers related to lines or ICU equipment. As we previously saw that is a big barrier as far as the amount of lines that a patient may have. And then finally, determining any communication barrier with the patient that may impact mobility. For instance, if a patient is intubated, figuring out a way to communicate effectively with the patient is important throughout the session, especially if they're needing to, stop whatever we're doing abruptly. It's important to figure out a plan for communication during the session as well. So some physical therapy interventions that we play a role in is education, whether it's educating the patient or the patient's family members on things that they can assist with when they're there at bedside, or things that nursing can do when we're not there. Positioning is key, also making sure that patients, when they are, say, up in a chair, but they're still pretty low functional level and not able to move around as easily, that we stress the importance of, trying to weight shift to make sure that they're, protecting their skin and they don't end up with any pressure ulcers. And then postural retraining, so working on sitting edge of bed or standing, working on trying to get patients' postural strength back, especially if they've been laying in bed for prolonged periods of time. All of those muscles that help support our posture have weakened, and so we want to make sure that we're working on regaining the postural strength as well. And then exercises including range of motion, strength training, endurance training, and then pulmonary interventions such as inspiratory muscle strength training, incentive spirometer, other breathing exercises that we may implement with our interventions as well. And then balance activities is another key thing, especially for patients that we identify as being high fall risk. We want to make sure that we incorporate those activities to work on that impairment as well. So if a patient's not medically able to progress with mobility activities but are awake and engaged, maybe we'll start off with some resistance training in bed. So you can see here in these pictures, the patients using the what we call a TheraBand, which is a resistance type band, to start working on some strength training while in bed. And this is great because we can leave that TheraBand in the room attached to the bed rail with the patient, and they can continue to work on those exercises even when we're not there. And then here we have an in-bed cycle ergometer. These are great with patients who maybe are beginning to wake up from sedation or are a RASS of -3 or -2. These in-bed bikes can passively cycle the patient's legs, but also allows the patient to begin to actively cycle, and it can provide a breakdown for the physical therapist as far as how much of the time was spent passively cycling versus actively cycling. So this is cycling with functional electrical stimulation, which is a step up from just the in-bed cycle ergometer. And this can allow facilitation of muscle contraction in sync with the cycle ergometer. And so this might be used for patients where we may not be getting any active cycling with just the cycle ergometer alone. And so we want to try to facilitate some sort of muscle activation with that patient. So we may bring in this functional electrical stimulation for that. There is inconsistency in the evidence regarding the efficacy of this particular intervention, but there might be a subset of patients where it could be beneficial, but more studies are warranted. Here we have a patient working on some balance training with WeFit. They're on a ventilator with a wheelchair sort of set up behind them for rest breaks. Again, this sort of shows the importance of figuring out what works for your patient and trying to engage them. And so, some patients you have to, get a little bit more interactive with some sort of game so that they're willing to participate in the therapy session. And again, we want to progress the patient to progressive mobility. That is the most functional thing that we can do. And as we saw from the systematic review, functional exercise has shown to be, more effective. And so working on bed mobility, rolling in bed, going from lying on their back to sitting edge of bed. If they're not, tolerating those transitions well, doing it in a slower, progressive way of working on head of bed elevation or chair position, and trying to increase the patient's tolerance to that. And then for patients that maybe are able to stand, but their standing tolerance is really limited by muscular endurance, we may implement a tilt table so that we can start getting sort of these longer sessions of weight bearing through the lower extremities at maybe less of their actual weight by, doing it at a decreased angle so they're not fully upright. Transferring to a chair, getting the patient out of bed is critical. Working on standing and pre-gait activities. So these are the things that we do before getting a patient, ambulatory. So working on sidestepping, taking a few steps at the edge of the bed to make sure that they're safe for progressing to ambulation in the hallway. So here we have a couple of pictures of some of the interventions we talked about. So on the left is a tilt table where you can see the patient is at a not completely upright angle, but they're getting some weight bearing through those lower extremities. This is a great intervention that not only can be implemented during physical therapy sessions, but something that nursing can do as well. And we can make recommendations for the angle to have the patient at, as well as the duration of the angle. And then the picture on the right, of course, we want all of our patients that are intubated up and walking in the hallway, but that's not always the case. But the times that we're able to do that, it's always very rewarding. And then identifying the patients where we may need assistive technology to really, maximize their mobility. So here the patient is utilizing a sit-to-stand assist device with a sling. Because she was a patient that buckled, like her knees would buckle frequently because she didn't quite have the balance and the muscular endurance. But with the sling, she was able to quickly recover into standing and continue walking with just having that sling there for support. So ultimately, our plan of care involves understanding the patient's baseline functional status and where they currently are now that they're in the ICU, as well as their interests and goals in order to determine their skilled PT needs. Establishing appropriate goals and providing interventions aligned with goals is essential as well. And then making sure the interventions and goals are modified based on patient's progression. We may also make activity recommendations for nursing and the patient's family when they're there at bedside, depending on how involved they are. And then ultimately making the appropriate discharge recommendation for the patient to get them back to their baseline functional status. All right, so now I'll turn it over back to Catherine to discuss role of nursing.
Awesome. So I'm going to give you a little insight into my perspective of the role of nursing, and then kind of what the research brings in about the role of nursing in early mobility. So a multidisciplinary approach is often discussed, and there's a lot of focus on including all members of the team when explaining, examining implementations of practice. So what's going to work for physical therapy, nursing, RT all together. So this article published in the Critical Care Nurse Journal in 2019, it talked about the positive impact of this bundle, the ABCDEF bundle that was implemented, and the benefits it had on patient length of stay, decreasing complications, and also improving family involvement. The article also touched upon, the challenges with implementing this bundle. But I think one of the things that we picked up on is that this article, there's not one bedside nurse that's included on the team. So you're really missing that perspective of the challenges of implementation. So the bedside nurse is the main implementer of the bundle. However, with that perspective missing, you really don't understand what can and cannot be carried out by the bundle. So as we've kind of stressed, that critically ill patients often require the expertise of both therapists and nursing, and also the assessments that they both bring. So I'm going to discuss a little bit about the nurse's role in rehabilitation. So the nurses kind of are that first line of defense. So they're really screening the patients for their rehab needs. So in the ICU, are they, walking laps around the unit, and maybe they don't need a therapy consult, even though the team has put one in? Or is the patient dependent at baseline? And again, are we going to progress any further? Do they need that therapy consult? We also are able to provide the patient's highest level of mobility in rounds. So during rounds at our institution, we will tell the provider team what the highest mobility level the patient has reached during that day, and that allows for an assessment. Have they declined? Have they progressed? If therapy hadn't been involved before, do we need to get them involved? And then again, we're also providing any updates and changes in medical status. So maybe this morning it was appropriate to work with the patient. They were doing really well, and over the course of the day, they've decompensated, and we need to have a follow-up. And then updates from rehab sessions. So, what were the barriers? What were the progression? Were lines an issue? Did the patient have episodes of hypotension? And then giving this feedback to the provider team. And then also implementing mobility recommendations from physical therapists. So as Steph talked about, whether it's the tilt table, or a lot of times we will listen for physical therapy to see how the patient did, so that later in the day we can also mobilize or even transfer to a chair with those recommendations. Some barriers specific to nursing. I know I talked about this before, but in that same article we discussed there were actually two specific barriers that were talked about in terms of nursing that were not found with any other disciplines. So the two themes were lack of confidence and the need to work overtime. So these two themes had not been discussed among any other disciplines, and I think that's interesting to take into account and for other disciplines to think about when it comes to involving nursing. So Krupp et al. Identified a significant gap in describing the role in nursing in early mobility interventions. And I think in terms of nursing, there's a lot of nurses that identify this significant gap as well. We're the largest providers of direct care. Nurses and PTs are most frequent provider of mobility. And there's a need to identify the roles and make this important consideration about mobility interventions. So what is the impact of early mobility? Nurses are managing pain and sedation, as we talked about. That can be one of the barriers, but it also, with coordination, can help prepare the patient going forward to mobilize. And then also the utilization of an early mobility protocol or algorithm. So this systematic review by Krupp et al. Looked at how PTs are working together in the future to improve functional outcomes. I think there's really an importance to really clearly define the role of nursing during mobility, and then also what it looks like the role of nursing and PTs together. So how are nurses making decisions regarding mobility standards and determine which patients need PT interventions? As we said in the previous slide, oftentimes nurses are the ones that are recommending PT to the team if it's missed, or, saying, no, we don't need PT at this time. And then looking at how nurses prioritize mobility during busy shifts. Where does early mobility fall when you're thinking about what's going on during the day and what needs to be done? This article found that there was a lack of role clarity between nurses and PT, and this often results in the patients receiving variable level of activities. This conceptual framework kind of focuses on the key points and the barriers of mobility, but really what we're honing in on, that all these factors influence mobility, both in a positive and negative way. And it also affects the patient's opportunity to participate in early mobility. So the factors are all managed by bedside nursing, and you can see that they all lead to an optimal level of early mobility. So if you think about all of these being managed by nursing, it seems, to make sense why it's essential for that open dialogue between rehab therapists and nursing. So this article by Hoyer et al. Strive for that common language when measuring and discussing a patient's mobility. So having this common language creates a better outcome for the patients. So utilizing measurements that have a good psychometric properties between disciplines. Use one that works for your institution and that's feasible to facilitate. So at Hopkins, we use our HLM goal calculator. So it's a mobility program protocol that's driven by a standardized approach in setting specific mobility goals each day. So the nurse will calculate an impact score, and that impact score tells you what mobility goal the patient should be reaching during the day. This mobility score is presented during rounds, and it's also discussed with the physical therapist. The expectation is that the physical therapist is reaching this goal and nursing is independently reaching this goal as well. And then finally, looking at Mai et al., they talked about fostering interprofessional collaboration and critical thinking between nursing and physical therapy students. So it looked at what conversation and having these pre-conversations, how this impacts the patient. So really what they drove home was that sharing of knowledge across disciplines was beneficial. So I think we'll all continue to see a growing trend of healthcare programs implementing these interprofessional collaborations, because I think there's been a lot of research that supports them. And really, as we've talked about throughout, making sure that it's appropriate for your discipline disciplines, but then also appropriate for your institutions. So we'll do one more question. Having a common language across disciplines is key in sustaining early mobility programs. Select one outcome measure below that is reliable between nurses and physical therapists.
Okay, that was a tricky one.
Yeah, I don't know if I defined it with those languages, so that was probably my fault. But the activity measure post-acute care inpatient mobility short form.
Right. I won't take up too much of your time. We're going to quickly go through the role of a respiratory therapist when it comes to rehab. So a couple of the things that we think about is staffing and scheduling, such as, do we have enough staff on today to cover you if you have to walk a patient? So what that looks like is at Hopkins, we staff about 15 therapists per shift to cover the various ICUs as well as step-down units and floors. Mainly in the ICUs and the step-down units is where we'll be mobilizing our patients, because that's where more of our chronic patients on the ventilators are. So are there enough RTs staffed? In the ICUs, we have about 2 to 3 RTs staffed on the floors, and step-down units is usually 1. Your patient, does your patient have any procedures that they have to go to that day? If so, there might be some sedation that's given that would affect whether they're able to get up and walk. Another thing that we look for is, do we have a session scheduled with speech where they're going to be working through being able to talk and communicate with the team? And then we look at just how the patient is doing for that day. If it's an intubated patient, are we planning on extubating them? If it's a trach patient, we have a trach collar scheduled for them. When it comes to managing the airway, that primarily is just as it sounds. We want to make sure that our airways are secure, that our tubes don't come out during these walks. So what that looks like is making sure that the tubes are secured via the tape or the tube holders that we use for trach patients. That's making sure that they have trach ties that are about 2 fingers width around their neck. We look at patient comfort. Does that patient have a history of having bronchospasms before or after the walk? Sometimes we may think of things such as, let's save their inhaler or let's save their treatment for after the walk, because that would help with their shortness of breath. If the patient has pain medicine scheduled, depending on if that pain medication may make them sleepy or not, we may schedule that for after the walk. And the last thing that we kind of look at is our equipment setup and management. So we only have a few of these walking ventilator setups, as we call them. So is it being used by another patient, or is another patient scheduled to use it that day? If so, then we have to divvy up the time of the RT, the nurse, as well as the physical therapist. We may see one patient in the morning and then see another patient in the afternoon. That way we have enough time to clean the apparatus in between and there's no cross-contamination. Next slide. All right, so I did a brief overview on the last slide, but now we're really going to get into things. So a part of staffing and scheduling that we really focus on is the communication. And that's not just communication from RT to RT, it's communication between the nurses, the doctors, the physical therapists. Because if a patient had a really rough night where we may have had to increase their settings, we definitely don't want to walk that patient. We don't want to overexhaust them or tire them. We look at the goals of care for that patient for that day, such as, do we have a goal of having a 6-hour trach collar trial, or say a 4-hour trach collar trial? Do we have to get that person up to the shower so that they can bathe? These are different things that we look at to kind of determine how we flowed throughout the day of getting these patients up and walking them. Are there times that the RT is not available, such as if we have a bedside trach procedure that we have to do? That's going to take your RT away for that period of time. Or if we're using speaking valve with the patient and there's a family meeting, the RT is going to be not available for that as well. And we also do attend rounds to get an idea of what's going on during the day. So we may be busy with rounds, we may not be able to walk right away. For the spontaneous breathing trials in trach collar, again, if we are going to plan on extubating a patient, we're going to put them on an SBT. If they are doing well on a spontaneous breathing trial, we may decide to extubate them right then and there, in which the RT is not needed for physical therapy in the afternoon, or we may walk them on that spontaneous breathing trial, and if they do well, extubate them right after. Same thing with the trach collar trials. Typically, we try to get our patients up and walking before we put them on the trach collar trial, just because they're already exerting themselves and now they can relax a little bit. Next slide. So number one responsibility of the RT is definitely the airway. We want to make sure that our airway is secured. We want to make sure our trach ties are secured. We're going to want to make sure that we have an ambu bag and mask ready for our trip, because you don't know when you're walking a patient if that patient is going to become short of breath or not. You don't know if there's going to be a cardiac event that happens, so you want to be as prepared as possible with that. Now, our equipment. We use transport ventilators. We sometimes will use the bedside ventilator for just simply getting the patient up and walking them in the room. We may use an ambu bag depending on the settings that the patients are on. And in this picture right here, this is actually a transport high flow nasal cannula that we'll often use for patients. And we also will walk patients on BiPAP. So one of the main things that you want to make sure of when you are deciding to take this walk and determining how much of a walk this patient is going to be on is having enough oxygen tanks. You never want to run out of oxygen. It's just going to put you in a bad situation where you have a shorter breath patient and not enough air to give them. Patient comfort, in my opinion, is the number one thing. You have to watch your patients during a walk, and the more that you walk the patients, the more that you can see and anticipate their needs. Some of these needs may be increasing the amount of oxygen that we're giving a patient if they are on a high flow nasal cannula. Sometimes that might just be increasing the flow to help them recover. If patients, as I mentioned before, have medications that are scheduled, we might think about rescheduling that medication to be before or after the walk. It just depends on our patient's comfort. If we know a patient is generally in a lot of pain prior to a walk and the walk makes that pain worse, providing that medication doesn't decrease the respiratory rate, we're going to be giving that medication to the patient ahead of time to facilitate a good walk. If the patient is on assist control mode and they are breath stacking or trying to take a breath while the ventilator is delivering a breath, we may need to either A, increase the amount of volume that we're giving because maybe they're air hungry. B, we may need to increase the flow that we're delivering, or we may put them on pressure support. You may find a lot of times when the patients are up and walking and moving, the reason why they're fighting is because the ventilator is just delivering those breaths and giving it to them over a period of time that the patient's not comfortable with. So putting them on pressure support, which allows them to determine their own rate and the own tidal volume that they want to take, may actually be a lot more comfortable for them, similar to how they would be breathing if they didn't have the tube. So a couple of the things that we do monitor when we are walking these patients are our respiratory rate. Has that gone up? Our tidal volume, do we see a decrease in that? Our oxygen saturation, is there a decrease in that? Is there an increase in our airway pressure as well as our work of breathing? Things like this will affect your patient's walk. They will affect how far your patient's able to walk and how comfortable they are when they're walking. Most patients find the transport ventilators very uncomfortable. It's a different way of delivering that flow, that tidal volume, and that pressure to them versus the conventional bedside ventilators that they're used to. So that's pretty much it for the role of RT. And I really want to give a round of applause to Steph and Catherine, because this is an amazing team to work on. I loved working with them when I was at Hopkins, and I love that I got a chance to do this presentation with them as well.
Thank you, Deidre.
Mhm.
I do have to hop off, I'm sorry.
Oh, no worries. Bye, Deidre.
Thank you.
Thank you all so much for such a wonderful presentation. At this time, like if any of our audience have questions, please feel free to type them into the question box and we will take them one by one. I think I'll start us with maybe one question, and if you guys can speak to it from the different disciplines, I think would be really helpful. How have you been, I think Deidre spoke a little bit to it, but how have you been successful in advocating for adequate FTEs to actually make that the norm versus, oh, it's really cool to pilot out ×1, or we're only able to get to that once a week or twice a week?
Yeah, I'll start us off with from the physical therapy perspective. So, really it has been using that evidence to, show that if we implement this, if we, do early mobility on the ICU, we're going to see a reduction in the ICU length of stay and the hospital length of stay, and that's ultimately going to affect the bottom line, right? So hopefully we're showing that you're seeing decreased overall cost for patient care, and that's justifying, having a physical therapist, every day on the ICU to see your patients. And that's really the simplest answer I can give you from the physical therapist side of things.
Yeah, I think from a nursing side of things, working for an institution that prioritizes mobility, you can see in our institution the multiple work groups that they have that are nursing focused and mobility, and then bringing those disciplines together. And I think when that priority is placed and those expectations are placed, then it doesn't lag and you don't see that decrease in FTEs.
Are there, I think, from an FT, I know Deidre spoke a little bit to that in terms of how they're staffed and seeing what the needs are and then adjusting accordingly. Are there like acceptable patient therapist ratio, both from maybe an RT and a PTOT perspective, if you're gonna pursue an early mobility program?
So there's no like difference in the amount of say patients that one of our floor patient PTC versus our ICU physical therapist see. We're still held to the same sort of standards in the number of patients that we see. And because that varies across the board at various institutions, due to various reasons, we don't really disclose that exact number regarding that. Yeah, because there's many reasons for why the FTEs could be different at each institution.
We have a question in the chat that's asking to define how you measure work of breathing.
Yeah, so great question. I wish Deidre was still here. But I think what she was meaning from like work of breathing is, the patient's respiratory rate, do they physically look like they're working hard to breathe? And, even if your objective data doesn't tell you otherwise, maybe there's other reasons why their work of breathing could seem higher, whether it's due to patient's anxiety level, with being in the ICU environment. And so, trying to, make adjustments, not just for what you're objectively seeing, but also how the patient is appearing and physically presenting to you there in the moment.
And I think it's also important to consider what that patient's baseline is. Is this somebody that's normally tachypnic? Is this somebody that is tachycardic? And having that conversation, because between nursing, PT, and RT, what they are comfortable with, and what, at what point are we going to say, okay, this patient is tiring versus their baseline.
And then I think the follow-up question from Donna there was in regards to looking at the waveforms on the ventilator. So that is definitely something that not only is respiratory therapy looking at, but physical therapists will look at that too to determine if the patient is breath stacking. And maybe it does become a discussion between PT and respiratory therapy of like, should we put the patient on pressure support? And is there anything that, you can do from the settings to, help the patient sort of sync with the ventilator a little better.
Mm-hmm.
Awesome. Were there any further questions for our panelists?
I think there was a hand raise, and I don't know if that was also Donna who ended up putting her questions in the Q&A box, but.
Oh, no problem. Awesome. Well, I don't see any further questions. We'd like to thank you all for a wonderful session and for a very insightful talk, a very practical talk. We appreciate your time. We appreciate your expertise, and we'd like to thank all our audience for joining us today. Be on the lookout for more information regarding our October programs, and we hope to see you all at Spike Out Sepsis in September. Hope everyone has a good afternoon.
Bye. Thanks.
Thank you.